Welcome to another session on ACLS Update 2025. This session will exclusively deal with the post-cardiac arrest care. What are the recent changes or updates in 2025 AHA guidelines and the importance of post-cardiac arrest care. So the post-cardiac arrest care begins with initial stabilization phase. In this initial stabilization phase, the first step includes the assessment of the airway, whether the airway is patent or not. If the airway is patent, need not worry, apply oxygen. If the airway is not patent, you may place or exchange an advanced airway. That may be an endotracheal tube or a supraglottic airway device. Use end-tidal CO2 in the monitor to confirm placement of endotracheal tube. So, placing a supraglottic airway device may need to open the mouth. Step 1, lubricate the device, insert the device and position the device. In case you are not able to secure the airway using endotracheal tube. So, this is regarding the supraglottic airway device, the IGEL, or use of video laryngoscope in case of a difficult airway. Initial stabilization phase also includes assessment of breathing, in which you titrate the oxygen to maintain a SpO2 target, again the recent update of 90 to 98%. So titrate your oxygen to maintain this saturation target. Again, the ABG target, the PO2 target should be between 60 to 105. Adjust your FiO2 on ventilator. PaCO2 targets of 35 to 45 in absence of severe acidemia. Again, adjust your minute ventilation in the ventilator. Initial stabilization phase includes assessing the hemodynamics, the circulation. Mean arterial pressure targets of more than equal to 65 millimeters of mercury. So adjust your fluids and vasopressors accordingly. Initial stabilization phase, the D, 12 lead ECG, diagnostic testing include 12 lead ECG. You may obtain CT head, chest, abdomen or pelvis, which may be considered to rule out the cause of the arrest. Role of echocardiography and ultrasound has crept in, and again there has been an article which we will discuss in later on. For the initial stabilization phase, what is the role of echocardiography or ultrasound machine? While investigating cardiac activity, it is a top priority during cardiac arrest. Certainly for reversible causes of cardiac arrest such as tamponade physiology for pericardial effusion or right heart strain from pulmonary massive hemorrhage can be appreciated on the recorded scan. Because review of the ultrasound image takes place while compressions are ongoing, ultrasound operators can take time to carefully look beyond the left ventricle for other cardiac findings. Procedures like pericardiocentesis or TPA would be initiated if needed under ultrasound guidance. Presence of hemodynamically significant pneumothorax or pleural effusion, free fluids from the abdomen, catastrophe, enlarged aortas may be appreciated on ultrasound. So depending on the length and the duration of resuscitation, ultrasound operators have an opportunity to find the pathology due to intervenable non-cardiac causes. Cardiac arrest may lead to expedited life-saving treatments. An article by Andrian Wong, Phillips Vignon and Chiara Rova has given a protocol of how to use ultrasound in the cardiac arrest. Confirm cardiac arrest definitively if the heart is not beating. Confirm the effectiveness of the chest compression, whether your hand placement is directly over the chest and is compressing the heart or not. Aid interventions like placement of the endotracheal tube, confirming the presence of endotracheal tube, whether in the trachea or falsely placed in the esophagus. Placement of venous access, that is taking the central venous access in the emergency. Reversible causes has to be ruled out, which can be helped with the help of ultrasound. As we can see that to rule out the hypovolemia, tension pneumothorax with the presence of a barcode sign, pulmonary embolism to rule out DVT, right heart strain, immediate post-ROSC care. Again, evaluating the may take help of transesophageal echoes if present to rule out RWMS. Again, scanning the lungs to rule out to decide about the fluids, presence of pulmonary edema, presence presence of a consolidation or a pleural effusion or a collapsed lung. Rule out or check for perfusion. So again, it can be of one of the help means to scan the kidneys for perfusion. Again, it can also be used for scanning the brain to look out for signs of raised ICP, to look for midline shift, or to look for the transcranial Doppler. Or and else the other thing is to look for or take the venous SS or arterial SS. So again, these are the points where ultrasound would help you definitely in cardiac arrest or post-ROSC care. What is the definitive role of ultrasound? Next step comes the continued management. Once you have initially stabilized, now you have to treat the etiologies and complications. Maybe you may need an emergency coronary angiography if persistent ST segment elevation is there, severe myocardial ischemia is there, patient's presence of cardiogenic shock and recurrent ventricular arrhythmias will compel you to go for an emergency coronary angiography. If there is a refractory cardiogenic shock, use of mechanical circulatory devices and support devices may be mandated. So this is regarding the continued management. Now, once if the continued management is ongoing, you will put off the sedation and neuromuscular block and see whether your patient is able to follow the commands or not. If the patient is not able to follow the command, then as per the update of 2025, you have to initiate a deliberate strategy of temperature control to initiate it as soon as possible. So how much temperature has to be there? It has to be between 32 to 37.5 degrees Celsius. For how much duration you have to make this deliberate strategy of temperature management? By around 36 hours. Do not infuse cold IV salines to achieve a hypothermia. Use cooling blankets or devices for achieving this hypothermia. Once the hypothermia has been achieved, maintain it for 36 hours and then start gradual rewarming at a rate of 0.25 to 0.5 degrees per hour till the temperature of 36 degree and more is achieved. Get an EEG done and on clinically rule out seizures if present. So once this has been done, if these all tasks has to be done if your patient is unable to follow the commands. If the patient is able to follow commands, continue your ongoing critical care management. Now it comes to prognosticate the family post cardiac arrest about the prognosis of this patient, which has achieved a ROSC and you have provided a post-ROSC care. So always, as per the new recent update, use a multimodal approach with delayed impressions more than 72 hours from the ROSC or achieving normothermia. For prognostication, use a multimodal approach. Now, this may include the CT brain once ROSC has been achieved. From there, imaging, CT or MRI, getting a SSEP, somatosensory evoked potentials, getting EEG done, status myoclonus if present, send serum neuron specific enolase post 24 hours of the ROSC, target temperature management, that is the specific temperatures of 32 to 35 degrees Celsius has to be initiated and continued for at least 36 hours. Post 36 hours, gradual rewarming over the next 24 to 24 hours has to be done. Limit sedation. See in EEG burst separation or presence of persistent status epilepticus, pupillary reflexes, corneal reflexes, quantitative pupillometry, and incorporate these tests for the multimodal prognostication at least 72 hours after normothermia or ROSC for prognosticating the patient. So these again were the updates. Why post-ROSC care is important? ROSC can be a stepping stone for good, meaningful survival with a good quality of life. So you have achieved a ROSC, your task is not over at that point. To achieve that, we must be able to apply good quality post-ROSC care, aggressive and preemptive neuroprotections. So you may let me live or you won't let me die. It has to be decided by your post-ROSC care. Once you have achieved a ROSC, what quality of life? If you provided a good ROSC care, you may provide a good quality of life.